Evening. But before we introduce our guests, we would like to go ahead and do some introductions. So I will start it and then popcorn it to the next person. So my name is Rhea, and I am one of the co-chairs of our Empowerment Congress Homelessness Working Group, along with Dr. Orduña, who is with us in spirit this evening. And I am going to pass it over to our founder, Supervisor MRT.
Well, thanks very much, Madam Co-Chair, and welcome to everyone. We're delighted that you are here with us for our regularly scheduled meeting. This is an important engagement. It continues to be, and your presence makes it even more so. I won't belabor the point. I'll have more to say in a moment, but in the meantime, let's hear from the Honorable Vincent Meredith Harris. Well, we would hear from you if you were unmuted, sir.
Really excited for today's meeting, and to kick it off, I'm going to share a recap of our meeting last month on November 14th. During that meeting, we started the discussion around people experiencing homelessness, causes of mortality, and certain death rates, and we heard a perspective from the medical examiner's office. We would like to continue that discussion tonight. And so I am going to pass it to Supervisor Mark Ridley Thomas to share a few updates with us and kick off our party.
All right, thanks so very much. Once again, delighted that you are here. Madam Co-Chair, are we going to say a word about practice? You're going to share a screen, or what's your disposition in that regard?
I would absolutely love to share a screen.
Okay.
One moment, please. Oh.
That's Dr. Nicholas's.
Yeah, sorry, I unmuted myself. I muted myself. So I'm going to share my screen, correct? No?
I'm going to share a screen right before that.
Oh, before that. Okay. All right. Let me stop. Oh, sorry.
Thank you.
Yep.
Okay, Supervisor. Right.
Not critical on rail if you're having difficulty. Oh, here we go. So, let me draw your attention to praxis, our weekly interface between reflection and action. Part of what we do and the Empowerment Congress is to educate, engage, and empower. 33 years in. We'll make note of the fact on January the 25th, we'll have our 33rd annual summit, focusing on where do we go from here, chaos or democracy. Make sure that you sign up early. We'll packed out audience, and you won't want to miss it. One of the workshops will focus on homelessness, specifically related to the impacts and the benefits of Measure A as it relates to South LA in particular. What you see here is praxis. You'll note that it's our 135th issue. And what we do is aggregate on a weekly basis a range of articles that focus specifically on homelessness, houselessness, housing insecurity, and what we need to know and do about it. So this piece looks specifically, thanks Vincent for dropping that in the chat, 1 in 4 interim housing beds in LA unused over the past 5 years. More can be said about that. Look at that. Ray, move that up a little bit so we can see what the next article is. Then we talk about a piece coming from the Office of the Mayor and a new initiative being launched. From there, we looked at LA City Council approving the mansion tax spending plan and the guidelines. Then the Enterprise Partners did a really extensive report on the matter of home key, worth seeing. You get the picture. We look broadly at invisible people. The next article um, tells the story of how AI is being used to predict and prevent homelessness. And so, what we try to do is locally, statewide, and even things that are going in other parts of the country. We do it on a weekly basis to advocates, policymakers, decision makers, um, uh, informed, and this ends up being a really useful tool and resource. And so, if you're not signed up for Praxis, please make sure you do so. We'll try to get something dropped into the chat so that you can be as informed as possible. Madam Chair, that's the extent of what I wanted to say in terms of a plug about Praxis put together by the one and only Janice F. Martin, consultation with MRT, brainchild of Vincent Meredith Harris. All right. Having said that, delighted to have the opportunity to welcome Will Nicholas. He already indicated that he's been connected with the county for 9 years. And to the extent that that's the case, we applaud him for nearly a decade of service in the Department of Public Health. Prior to that, he was at the Fielding School of Public Policy at Department of Public Health, School of Public Health at UCLA.
I'm sorry, where was that again?
We won't want to invoke that with too much regularity. It's enough of that already. Madam Chair, can you control the mute button over there for Mr. Harris? He's unbridled. And then again, spent time at the California Endowment. He has seriously strong research chops. That's been the through line in his career, and it's an impressive career indeed. Undergraduate work at Cal, graduate work at UCLA, and for the master's degree, and then a PhD at Yale. And so, Dr. Nicholas, we welcome you, and we turn the floor over to you to enlighten us on the areas that are relevant to us in this specific niche pertaining to homelessness and the like. Will Nicholas, ladies and gentlemen.
All right. Thanks for the great introduction, Supervisor Ridley Thomas.
Yes, sir.
All right. So I am going to share my screen and let me know when you can see it. All right. Okay. So yeah, this is a grim and tough topic to talk about, but I've been working on this for a while now. Going to share with you actually unreleased data. Our next report is due out in January, and this is a pre-release presentation. We're in the process of spreading the word, but also getting important input from folks like yourselves. So I hope this is a two-way kind of a dialogue. I have probably more to learn from you all than you have to learn from me. So there we go. So yeah, I'm just going to provide a little background. I wanted to present and discuss the data, but more importantly, I really want to talk about the recommendations, get your feedback on what we recommended last year and what any updates we should be thinking about this year. So basically, as you may imagine, public health departments, as a matter of course, at the state and local level, track mortality trends to inform prevention efforts. And we look at data by different causes of death. We look at various subgroups, and it's all in the interest of health equity and prevention, and informing those prevention efforts with data. But we typically do not have good data on homelessness. So partly because we don't typically, until very recently, and I'll talk about that in a minute, don't have any information on housing status on death certificates, for example, in most states. California just started that, I guess midway through 2022. So we took it upon ourselves, Department of Public Health, as we were, getting involved in all the homelessness efforts around when Measure H was passed, and really worked to get up as best account as we could of the homeless deaths in LA County. We published our early findings in a prestigious journal. So this is data that we stand by and are proud of. We do our best to make sure we don't miss. The idea is to make sure we count everybody. We don't miss anybody. We do restrict ourselves, for example, to HUD criteria in terms of our definition of homelessness. So, but that's the basic criteria that we use. But we sort of scour medical examiner data. I heard you heard from Dr. Ukbo recently. We also use state death records. And then we use the homeless count as a denominator, right? Because we're not just interested in the death counts, but we want to look at the rates, the population rates. And so the homeless count helps us with that. And the homeless count includes a demographic survey, which allows us to do some helpful things like compare subgroups of the homeless population, adjust for age, and things like that. So, it wouldn't be possible without the help of a lot of partners. And so when we released our first report in 2019, the Board of Supervisors at that time established a homeless mortality prevention work group. So the idea was this wasn't just data for data's sake, this was data for action. And so still to this day, a working group of mental health, health services, public health, medical examiner, the CEO Housing Initiative, Homeless Initiative, LASA, are engaged in regular conversations about progress on strategies related to the recommendations that we put in our reports. And then finally, kind of gets me where we are here today, it was we also seek input from community stakeholders and people with lived experience, because that's critically important. And I'll happy to report that actually just today I spent 2 hours with the youth lived experience advisory group at LASA. So it was with 10 very highly engaged, super intelligent, amazingly articulate young people who had experienced homelessness. And so it was a very, very informative and very humbling day for me. So I'm going to start with jump right into the data. So this is we have data through 2023. Basically, it takes us a little, because of the various methods we use, it takes us a little while to put this together, but we're trying to get to the point where we get the data out within a year of of the year that the data is from. So what this graph is showing is that, as you can imagine, we had a very, very steep increase in the mortality rate. The pink line represents the rate per 100,000, and the blue bars are the actual numbers of people who died while experiencing homelessness each year. As you can see, both have increased over time. Just this past year, our latest number was 2,508. It's the largest number we've counted so far. Put that in perspective, if you average that over a year, that's about almost 7 per day. So every day, if you were to average that every day, 7 people experiencing homelessness die in LA County. We think this is the fact that the death certificate now includes a homelessness field. I think we've done some analysis on this. I'm not, it's a little in the weeds, but we think it may have a small impact on our count. It's a good thing. We're doing a better job counting. But we're going to continue to track that into the future. But yeah, so we're just over 2,500 deaths. And so, right, so we had 2 years of alarming increases coinciding with the COVID pandemic and the fentanyl epidemic, between, it really hit LA really hard beginning in 2020 through 2021. But overall, we saw a flattening of the curve in 2022, and the I guess tempered good news is that plateau is now a trend. I mean, we have now, two straight years of a plateauing in the rate, still way higher than it was from 2017 to 2019. So it's nothing to be too proud of yet. But we've turned the curve a bit, and now our job is now to start trying to get those rates back down closer to where they were before the pandemic. The next slide shows you, first of all, these are the top 5 causes of death among people experiencing homelessness. So the red line is overdose, drug overdose. That's number 1. Number 2, the dark blue line is coronary heart disease. Number 3 is traffic deaths, and those are overwhelmingly pedestrians hit by cars. It's the 3rd leading cause of death, which is not even in the top 10 in the general population. And then the 4th is homicide, and the 5th is suicide. And COVID showed up there for 2 years in about the 4th spot, and then dipped below number 10. So let's talk about the overdose line first. This is where, this was fentanyl, and I have some data on drug types that shows this. But what this graph shows is that in 2023, for the first time, we're seeing a flattening of the curve for drug overdose deaths, which is good news. You'll notice that for all causes in the previous graph, the flattening started a year earlier. We think has something to do with the fact that, something to do with COVID. So COVID, as you can see here, COVID went way down in 2022. So overall, the flattening of the curve started in 2022, but really it doesn't start for overdose deaths until 2023. So still extremely high. Again, there was, I guess, 1,123 overdose deaths in 2023, which is about 3 per day. So 3 people on the streets dying of overdoses every single day. I'm going to go back to this graph in a second to look at the other causes of death, but I wanted to show you this also first. This is just shows an association. It's an interesting one, I think. These blue bars, I got data from the state on their naloxone distribution program. That's Narcan. That's the opioid reversing medication that reverses fentanyl overdoses and other opioid overdoses. You can see that we were a little slow on the mark. I mean, we didn't start to see real Narcan really flooding the communities until 2021, increasing considerably through 2023, and we really see the flattening of the overdose curve kind of when we hit this critical mark of about 400,000 doses in 2023. 2024, this doesn't include all of 2024, obviously. We haven't, the year's not over, and it's not included here, but this is going to be closer to 500,000, which is great. And really, so what I was worried about is that, we're finally up to critical mass here, curve flattening, and then we sort of, taper off our harm reduction efforts, but that continues to be well up, like close to 500,000 in 2024. So this is not causality, but I think it's it's a pretty good indication that that this one harm reduction strategy is associated in some way with the flattening of this curve. And if you if you have burning questions as I'm going through this, feel free to jump in. I can also wait until the end of the data slides. I don't have a preference. So going back to the top 5 causes. So the second one is coronary heart disease. That's the the disease of older age, right? It's the leading cause in the general population. But we naturally, folks experiencing homelessness tend to die of heart disease 10 to 20 years younger than people who are housed. And so this is where issues of timely access to preventive and chronic care services through our street medicine teams and our mobile clinics really come into play. This heart disease mortality rate increased for the first time in a while in 2023. 1 year doesn't make a trend. It's a little concerning, but we want to wait another year to see what's going on there. But yes, we did see an increase despite the flattening in the overdose rates, an increase in heart disease deaths in 2023. The traffic deaths, again, which I said are overwhelmingly pedestrians hit by cars, increased by 50% from 2019 to 2021, and thankfully has not increased more, but has remained stubbornly high. It's kind of at a plateau 2 years in a row now. It's kind of flat. And so, for example, we're now going to partner with folks in our injury prevention program to do a small grant where we're matching these data on the homeless deaths with California traffic data that gives much more detailed information about the collisions, and writing a little grant to see if we can test out some specific strategies for reducing traffic deaths among people experiencing homelessness. We think getting people housed and safely out of harm's way and not in proximity to traffic is going to go a long way. But there are other sort of stopgap measures like lighting, reflective vests, you name it. We want to talk to folks to see what's going to help, because I think the number here is something like 4 per week. We have 4 people dying, 4 homeless pedestrians getting hit by cars every day in LA County. The homicide rate went down considerably this year. That's great news. Went down across all age groups and all racial ethnic groups. So that's welcome news. It had been going up for the past 2 years. It had been going up in the general population, although it started going down last year in the general population, but it's nice to see that that's going down in the homeless population as well. And then suicide has always been the 5th leading cause of death. It's fairly steady, but it's still, and we have comparisons to the general population, but it's still about 8 times the rate of suicide in the homeless population versus the housed population. So we saw this. This just shows we were able to also look at drug types involved in overdose deaths. And this is something you can imagine, but it's data to show it, which is that, this is the percentage of different drugs that were detected in overdose deaths. So they add up to more than 100%, because most overdose deaths involve multiple drugs. But the percentage involving fentanyl shot up from 18% in 2019 all the way now up to over 70% in 2023. Meth always has been higher, and still is a little bit higher, although they're getting close. Again, meth isn't as deadly as fentanyl, but there are still a chunk. I think it was, I have another slide on this. About 19% of the deaths were just fentanyl alone. So that's the drug that's most likely to be. And anyway, I guess what I want to say is that fentanyl has effects on the cardiovascular system after prolonged use. So we tend to see that people who die of meth only, not mixed with opioids, tend to be older. And then, of course, all the other opiates are going down as fentanyl goes up. All right, this is a slide that shows, and we're able to do this, just for age, and we have good data from the count on demographics, and it shows what people have found in other cities where they've looked at homeless mortality. And the first thing I want to talk about is that the yellow line is black and the orange line is white. And consistently, the mortality among white people experiencing homelessness is higher than the mortality among Black people experiencing homelessness. And there are theories in the research literature about why that is. And I thought it might be interesting to throw that to the group. Like, is that a surprise? It surprised me when I first saw it, but wonder if that surprises anybody in this group, or if anybody has any thoughts or ideas about why the mortality rate. And this is controlling for the total population. So this is a rate, and it's also adjusting for the age of the two populations. Any thoughts about why the mortality would be higher in the white group versus the Black group?
Well, it strikes me as counterintuitive.
Yeah.
And it is not a new phenomenon. When I first began to dial into this discussion pertaining to deaths attributable to the range of things you identify of those in the homeless population, it is what caused a number of people to wake up. And maybe it's to be displayed in another slide, Dr. Nicholas. But when you look at this data and find that there are more people who are dying in the county of Los Angeles, on the streets of Los Angeles County, owing to homelessness, as compared to homicide data, it is startling. This demographic data, you might say, contradicts what people often say is the concentration of homelessness being the African American population, and yet not so when it comes to mortality. Right. So this is why I assert that it is counterintuitive. And the why, I don't know, has been sufficiently ever accounted for. And so perhaps, if nothing else, we will learn from you what your why is, if there is one to be appreciated.
Well, anybody else before I share what I have read? So what
I'm sorry, Dr. Nicholas. I was just going to say, perhaps it is related to either a survival mechanism associated with the duration of being without, so that if a person that may be more affluent who's never experienced shortage may find themselves in a higher level of crisis, incapable of coping with what has transpired in their lives that has caused them to experience homelessness. In contrast, perhaps, to folks who have been acculturated in an environment of shortage and loss, and therefore has adjusted to the coping and survival mechanisms that make the capacity to handle the experience of homelessness greater. That would be sort of how I would read that.
It's like a resiliency kind of it's a resiliency theory. Yeah. I mean,
that's dangerous. That's dangerous. Yeah. It comes perilously close to Daryl Gates' argument as to how and why African Americans could sustain chokeholds, and it wouldn't be as. So you got to be very, very careful with that one.
Yeah.
Well, I'm being careful, but if if you've experienced trauma, then you may have the a greater capacity to handle additional trauma.
I understand your point.
As a coping mechanism, that's all I'm saying.
I take your point.
I'd like to jump in here because
help him, Norman. Help him, Pastor Johnson. Help him.
Well, Vincent always helps me.
Yeah, well, help him tonight.
But I'm just wondering if, in fact, among whites, there's a greater isolation in terms of homelessness than what you would experience or what you have seen with blacks. So if in fact Black folk are in fact homeless, are they as isolated from community family as whites would be?
Mm.
Because I mean, my experience population, you have folk that will say we're not going to provide you with a place to live, but maybe in fact we'll provide some resources for you in your situation. So I'm just wondering if in fact that issue of isolation might contribute to what MRT said was counterintuitive.
I'm liking all this. Velvet, go right ahead.
Say that again. I didn't.
Oh, I was calling on. I'm sorry. There's somebody else. I'm sorry. I didn't mean to. If you were finished, there's somebody else.
That
Okay.
was my point.
Okay. I just see that somebody else has their hand up, so I was calling on them.
Okay, my thinking is, and I'm Velvet. My thinking is that we're familiar with trauma. See, they've lived lives that they didn't have to prepare for nothing. They just lived a regular life every day. Every day in our lives, we've had to be prepared for trauma, all kinds of stuff. Basically, I just call it all trauma. And at the end of the day, we've learned to be resourceful and to find our way. We wouldn't have survived as slaves. Think about it. All them other people come here with a meal ticket. We came here as slaves. And we've done more, and that's one of the reasons why so many people are intimidated by us, because we beat a lot of we beat a lot of stuff, and we keep pushing, and that's what they're afraid of about our people. And I'm just gonna be quiet now, but that's my insight.
Thank you.
Gotcha. All right. Well, thank you. Yeah, I mean, these are all I think very plausible explanations. And what I'll do is I'll tell you what the sort of the research kind of researchy academic perspective is, because that's where I was able to read people's conclusions from similar findings in other American cities. And it's a different interpretation. And anyway, I think it's fascinating. So I'll tell you what it is and then we can talk about it. But it is rooted in a structural racism, perspective. And the theory is, well, because of structural racism, it is easier for Black folks to fall into homelessness strictly due to socioeconomic conditions. Whereas it is harder for white people to become homeless. It takes more years of trauma and adversity for them to finally fall into homelessness, such that when they are homeless, they are in a worse state of health, of drug use or whatever it may be, so that they are less healthy by the time they become homeless than Black folks who are more able to become homeless because of structural racism for much more easily, just because of socioeconomic reasons. And I've sort of relayed that theory in certain places, and I get funny looks, because what you all are saying is it completely discounts any resiliency explanation, which is, there's no reason why that is not also part of what's going on here. But I'd love to hear how does that ring with you, the sort of academic perspective, because I don't think any, you know, I think it's probably a little bit of maybe a little bit of different things, but that's sort of the academic line.
It's unrefined from my point of view.
Yeah.
And the reason I suggest that, unless you have a demographic index that would then overlaid so that you would have to understand the gender, the age of the African Americans, not simply the socioeconomic status, but how old they are, how young they are, what their gender is compared to their white counterparts. So just to say that whites enter a state of homelessness and more challenged or deteriorated physical and or mental conditions, to my mind, is insufficient unless the data can be lined up to say more in a refined manner. Is that making sense to you, Dr. Nicholas?
Yeah, absolutely. Yeah, let's hear
So,
from, yeah. I yeah, you're right. It's a theory, and you would have to know that, yeah, it's not, and it hasn't been tested.
I mean, the epidemiology has to
Yeah.
go there in order for it to be plausible. Otherwise, those assertions I find not to be helpful and potentially misleading and could ramify in terms of the issue of racial stereotyping, much like what I initially said struck me as problematic from the point of buoyancy, therefore capacity to handle chokeholds more than other ethnicities.
Right. And I'll say, and I'll get to Paulette and others who have their hands up. But I think I mean, hear the voice of white academics thinking that this is an enlightened interpretation that attributes the difference to racism, but it but it also misses the mark, like you're saying. Yeah. Anyway, I've really learned not to lead with that, because it's
It's
just a theory and it's not really tested.
Yeah, well, it
Yeah.
certainly misses this mark,
Yeah.
Madam.
Yeah.
Give the
uh,
fun.
Yeah.
yeah,
So
yeah.
we got Paulette. Paulette's got her hand up.
Hi, can you guys hear me?
Yeah.
Okay, so my name is Paulette. I find my story kind of a very kind of a different type of situation. I'm homeless at this present time, and I've been homeless for over a year now. But not knowing that I was in the court system as a criminal for the past 20 years behind a misdemeanor and infraction traffic ticket, which caused my character to be looked at as a criminal while applying for government jobs, and raising 3 children as a single parent will be the cause, will be the beginning cause of my homelessness that I've just found out last year, that I was in that system for the past 20 years as a criminal. And then being a new founder of an organization that has reached high limits of being noticed, now being internationally noticed, the I would say game that a new business owner that really has no one to mentor, to be mentored from, and to learn the process, by themselves. It's a real big challenge. just doing what I know that's right and what should be done for basically my audience are the youth, and finding myself being wrongfully terminated without notification, which caused me to be evicted, myself and my husband, who served this country as a honorable discharged Army vet who recently passed away. So everything that I've experienced has been a trickle of horrendous experiences where I have never had the time to grieve or anything, and still being homeless.
Yeah.
So, it's been a struggle. It's just
Yeah.
something else.
Paulette, we thank you for joining us, and first and foremost, thank you to your husband for his service, and thank you for the insight that you shared. I think it definitely aligns with and contributes to the discussion that we've been having here. After the meeting, if you would like, I will put my email in the chat. If there's anything that we can do to help you through your situation, we are definitely here to do that. So thank you for sharing that. Velvet and Jolly, I am going to ask Dr. Nicholas if we can postpone some of the questions because you have a lot of great data to
Yeah.
share.
Okay,
And
so it's true.
I don't want to run out of time.
Right.
So I'm going to ask if we can postpone the
Yep.
questions to the end of your presentation.
Sure.
That works
Yeah.
for you because you have a lot of information.
Yeah.
I want to make sure that we're
Right.
able to dig into all of it.
Okay. But yeah, it's
Thank you.
so helpful to get that feedback from y'all.
Thank you.
Okay. So this is I'm not gonna a little talk about the green line, which is the Latino line. So notice that one's trending downward, particularly from 21 to 22. The story there's actually some more solid data to explain that decrease, and that is that the researchers who do the homeless count demographic survey published this, and they noted that actually during that year there was a huge increase in the proportion of the homeless population that was Latino, and it was specifically due to hardships from the economic hardships from the pandemic. And so these were people who were relatively young and healthy who began living in cars during the pandemic. And so, as you can imagine, as the population increases for any number of deaths you have, the mortality rate is going to go down. So that's less of an issue of fewer deaths and more of an issue of just a larger influx of folks into the population. So that's the story on that one. All right. This is the overdose mortality rate. Similar differences, white-black differences, although the trends are in the same direction. So basically, yeah, we saw this, increasing from 2020 to 22 in overdose deaths, followed by a flattening or a bit of a downturn starting in 2023. So it's good news for across the board, across the racial ethnic groups that we're starting to see that we're turning that curve on the overdose deaths.
That AP,
Yeah.
so is whites, blacks, Latinx.
Oh, sorry. The pink line is just everybody. It's
Yeah.
that's just to kind of give you that. That's everybody. All that. Yeah.
I got it. Okay.
Yeah. This is now looking by gender. This is another bit of a conundrum. So in the general population, typically male mortality rates are higher than female mortality rates, but not the difference isn't this great. You see in 2022, it's almost double. I mean, it's a little more than double. So there's something going on with the dynamics of female homelessness versus male homelessness that is causing the mortality rates to be lower among females. I'll just share one sort of story we heard from a lived experience group, which is that for example, meth. We heard that meth is a drug of choice for female people experiencing homelessness because of its effects on sleeplessness. So basically, it keeps you awake, it protects you from predators. So it's a safety strategy. Whereas opioids tend to, they're downers, they make you sleepy, they may make you more vulnerable. So, and because opioids tend to be more deadly than meth, that's one potential explanation. But I don't think that could explain it all. Yeah, we don't have to go into this one as deeply with the group, but yeah, so it's definitely gender differences as well. This is also overdose mortality rate trends by gender again, similar to the racial ethnic differences. Females lower, but similar shape of the curve. A little bit of an increase through 2022, followed by flattening and a decrease in 2023.
Homicide, suicide data, Dr.
There's
Nicholas.
there's two. We could do it. The numbers would be less stable. There's too few of them. I do these graphs only for the 2 top causes of death because there's more of them and I can get more sort of reliable estimates. So have not done these comparisons. I can show you just the raw numbers. And yes, typically in terms of like the percent of deaths that are due to homicide, they are they are higher. I can show you. Let's just do this really quickly. I have to throw myself off here, but so let me this one. Yeah, so here you can see homicide deaths. This is the percent. So you can see homicide. So this shows you the percent of deaths per group that are from homicide. So you see here that 3% of the white deaths were from homicide in 2022, but 9 and 8% of the Black and Latinx deaths were from homicide. So a much higher proportion of the deaths were from homicide for the Black and Latinx groups. Anyway, 2023, so we saw homicide go down across the board in 2023. So it's actually half the amount. It went way down in the Black group from 8% to 4%, but also went down a little bit for white and Latinx. So I don't have the rate curves because the numbers are small, but
Okay.
yeah, that's about what I can tell you about that. Let's see. Where am I? Okay, so this is and then we're going to talk about the recommendations. That's really what I would like to spend a lot of time on. So this is the comparison. This pink line is the mortality rate in the homeless population across time, and this is the mortality rate in the all of LA County across time. And this yellow line, this is just the simple ratio. So what this 4 means is that this number is 4 times greater than this number. So basically how you would say this is in 2021, people who were unhoused were 4 times more likely to die than people who were housed. So the mortality rate was 4 times greater in the homeless population versus the housed population. And so it's hovered around 4 for a couple of years. It went up to 4.5, 4.5 times greater in the homeless population in 2023. But that's really more because of a decrease in the general population rather than an increase in the homeless population. So, but anyway, it's gone up a bit. And so we I think it's important to do those comparisons. So anyway, yeah. So, and this is, fairly close to what other places in the US have found. So it's always going to be, it's more deadly to be homeless, unfortunately. And then this is new for this year. What we did is we looked at it by subgroups. And so if you look at these numbers, Black, Latinx, and white, so it was 4.5 overall, right? For 2023. But the difference for the African-American group is much less. So for whites, the unhoused population mortality was 7 times higher than the homeless population. Whereas for the Black group, the unhoused mortality rate was only 2.7 times higher than the general population of Black folks. So that's also interesting. So that kind of speaks to inequality is the way I interpret that. Yeah, I'd love to hear what folks think about that too, because this is the first time we're actually reporting these ratios by racial group. So basically what it's doing is saying not only what's the overall, the 4.5, what's the overall difference between the housed and the unhoused in terms of how much greater is the mortality rate, but like within these, so comparing Black homeless to housed, Latinx homeless to Latinx housed, and white homeless to white housed. And the difference is smaller for the Black group. And that, yeah, I can only think that has something to do with general inequality in society. But yeah, so that is and that is also not unlike what other cities have found. For male female, difference is not as great, but it's closer to 5 for male and 4 for females. Yeah. And then if you look at specific causes of death, the differences get huge. 48 point, this is basically what this is saying is that in 2023, the overdose mortality was almost 50 times greater in the homeless population versus the housed population. This is for everybody. This isn't by race, ethnicity. And I would say the reason this is so high is because I think drug use and overdose is so intertwined with homelessness. So it's so often that homelessness is precipitated by drug problems, and so they're so related. I think that's why this one is particularly high. But homicide is 16 times higher. Transportation related injury traffic deaths about 20 times higher. So, and then you might wonder why. I mean, overall is only about 4 times higher, and these are all higher than 4. And the reason it comes up is because there are some causes of death like diabetes and stroke and cancer and Alzheimer's, which are very high on the list for the general population, which don't even register in the homeless population. So so it kind of evens out. But these are showing stark differences in the mortality rates between housed and unhoused for these particular causes of death. So let me pause before I go on. I want to move on away from the data and towards sort of what we do about it. Is that all right with everybody?
Yeah.
All right.
Yes, please.
Okay. So this is these are our recommendations from last year. They're kind of an abbreviated format, but I'll kind of read through these quickly and kind of get your take on them. They're in groups. This first group is about ensuring rapid access to housing and shelter responsive to the needs of unhoused residents. It's so funny, MRT, you mentioned the piece about interim housing, 1 in 4 going unused. That came up actually in a group I had with the youth this morning. It was really impressive. But so anyway, so the first recommendation is just basically making sure that no matter who you're connecting with in the community, whether it's a social service provider or a healthcare provider or substance use program or whoever you might interact with in the service sector, can do housing navigation, has the tools to triage you and connect you to housing resources. So that's a sort of a training issue, making sure that everybody that has contact with people experiencing homelessness is trained in housing navigation. Second one is just the very broad one about sustaining and expanding the supply of permanent supportive housing and interim housing options, although that supply issue isn't always going to help, as you know, that a lot of that goes unused. But anyway, we still do want to make sure that the supply is expanded and sustained. We want to prevent loss of housing placements due to substance use. We had heard stories about people having lapses or people being kicked out of their housing because of substance use, and there was a push to be a little bit more lax on that because that leads to a lot of unnecessary evictions. And then making recovery-oriented housing available to those who would benefit from an abstinence-focused living environment. That works for some people, making sure that's an option for those people who want to take advantage of it. And then making sure that all congregate living settings have readily available overdose prevention services. So in this broad category of, access to housing and shelter responsive to the needs of unhoused residents, what are we missing? What are the nuances there that would need to be added? Anything that anybody would sort of add there? And Jolly, is your hand up from before, or is this a new hand? I see a hand there.
Yes, my hand is up. Thank you. I just
Actually,
wanted to.
sorry, Jolly, sorry to interrupt you. I think Dr. Nicholas, we wanted to resume questions after your recommendations.
Oh, okay. Okay.
Thank you.
Okay, well, I'll hold on.
Okay.
Thank you.
Okay,
Mhm.
so this is the cluster around ensuring rapid access to housing and shelter responsive to needs. Then there's a whole cluster around expanding harm reduction and overdose prevention services, targeting those at risk for overdose. So advocating for establishment of safe consumption spaces, which includes also things like clean needle exchange. That's an advocacy position because there's still not a lot of openness to that in California. Sustaining and expanding harm reduction and overdose prevention services in jails, hospitals, residential settings, and through street-based outreach and engagement. Sustaining and expanding welcoming drop-in spaces with access to harm reduction services and linkages to other services. Expanding telehealth and mobile substance use and physical and mental health services. Integrating peer-led services so that people with lived experience have a role in shaping the services. And then a specific one focused on more marginalized group, Black, Indigenous people of color, and transgender, gender nonconforming, and intersex. Those are all around expanding harm reduction and overdose prevention. This next group is about really focused on physical, mental, and substance use treatment services. So training medical providers, and this probably shouldn't just be medical providers, it should be a broader swath of health and social service providers, but training to be better understand and accommodate the special needs of patients experiencing homelessness. There's a lot of people are not familiar, and so not knowing about the unique conditions and circumstances means that care is not delivered in an appropriate way. Sustaining and expanding street-based primary and preventive care services with linkage to facility-based medical care for those with chronic conditions, just providing better chronic care. Facilitating access to more specialty cardiac care for those with heart issues. And then ensuring best practices for infectious disease prevention and control in shelter and other congregate settings. And this continues sustaining and expanding community and congregate setting-based mental health services for unhoused residents, lowering the eligibility threshold for initiation of substance use treatment, lengthening the time of engagement, and increasing the presence of community-based outreach and engagement teams to help people engage in these services. This is all part of a new initiative in our substance use program at DPH called reaching the 95%, based on this statistic that's out there now that 95% of people who have substance use problems do not acknowledge that they have substance use problems. So half the battle is just getting somebody in the door or beginning to even take the first step. Sustaining and expanding access to FDA-approved opioid addiction medications. And then one very specifically focused on traffic deaths, collaborating with municipalities, et cetera, to identify concentrations of fatal injury collisions, to inform community planning and strengthening local infrastructure and policy interventions specifically focused on traffic deaths. So that's a lot, I know, and because there's a lot that needs to be done, and we have a little bit of time left to add to these, to ask questions about these, potentially revise them. Yeah, I wanted to open the floor to, anything that you think might be missing or any nuances that we're missing here, particularly in terms of, mortality reduction.
First and foremost, Dr. Nicholas, we'd like to say thank you so much for that presentation. Both the data and the recommendations were very extensive and engaging. So thank you to you and your team at DPH for all of the work that you were doing to, collate these data and present them. I know we have a few questions, and so I'll start with Ms. Jolly Glover and then Ms. Reba Stevens.
Okay,
Jolly,
yeah,
go ahead.
thank you for taking the time to hear my question. I wanted to go back to the part where you were talking about the disparity levels that are focused on Black people in terms of their homeless rates.
Their mortality rates. Yeah.
Yeah, their homeless
Yeah.
rate, also
Yeah.
their mortality rate.
Right. Yeah.
Because
Exactly.
if they're
Yeah.
homeless, they're more subjected to being, you know, no longer in existence. But because of their resiliency, they endure more. So that may also have a lot to do with fewer deaths, even though there are more Black people that happen to be homeless. There's actually, out of the 8% of Black people that are in LA, or in 34% of them are homeless. So those numbers are really, really hard for that small amount of Black people. I mean, if you go downtown Skid Row, you know, unless you're colorblind, you're going to see mainly Black people. They're you know, you don't even need to take a real assessment. You could just visibly see Black people all downtown, even in LA. If you go on, you walk down the street, they're mainly Black people that's on the street. Very few white people on the street. They don't stay on the street long. Very few Hispanic people are on the street. You don't see them either. They get the resources. They get access to those resources. But Black people, they are the last to get the resources, if they get any. So I'm very concerned about how Black people are being overlooked. If they do get into some sort of um, body count, it has you put them together with every other person of color, and so that you don't see them as their differences, the things that they require, or the things that they're enduring may be totally different from everyone else. They have unique problems. Um, so that's one of my concerns. I think the numbers, may need to be looked at again.
Got it. So you continue to be surprised that the mortality rate would be higher among white
Well,
people
yeah, well,
compared to, yeah.
they're not built to be in the street like that. Or,
Okay. So it's a
their
resiliency. Yeah.
their ability to endure that kind of hardship, being in the elements. Yeah, of course, they wouldn't last too long. But the Blacks, they're able to stay and endure, although they are suffering. you know they don't like being A lot of them don't like being homeless, and if they're absent, if they're not conscious of being homeless, it's because of mental illness. So a lot of Black people are suffering from mental illness as well, that are homeless, and drug abuse.
Yeah.
So that I think, you know, they would fit in all of those categories in terms of need, in terms of the things that they're lacking. So
Yeah.
I think there needs to be more eyes and more attention there.
Yeah. Thanks, Charlie. Yeah. One thing I'll say is one thing I don't think I've heard, but which is another thing people say as well. The reason the white mortality rate is higher than the Black mortality rate among the homeless is because of drug use. It's because the drug use is the highest. It's the number one cause, and it's higher among the white people experiencing homeless. So that's the explanation. But we just for that sake of that argument pulled out overdose deaths and overdose deaths being equal, like as if there were no overdose deaths. We took all the overdose deaths out of both populations, and the gap persists. So to me, that further supports some kind of a resiliency hypothesis. So yeah. Bishop
Dr.
Smith.
Nichols.
Yeah. I'm sorry, do you want to call on people?
Oh, yeah, sorry.
Oh.
I know Reba had her hands up
Oh,
as
sorry.
well, so.
Yes, good
um,
evening, Dr. Nicholas. I want to just first say thank you and thank the previous speaker. So there's a couple of things. One is I do believe that it really is important to address the disproportionality of Black people, first and foremost. And then I'm really excited about recommendations. So you're asking for recommendations, and I'm assuming that you're asking in this space as well. So
Absolutely.
a few things. One is you mentioned early on about having conversations with people with lived experience. I'm curious to know when we're talking about substance use or abuse or overdoses, if that population of people with lived experience actually had the experience of substance use disorder. That's one. And then secondly, when we talk about harm reduction, I think it needs to be very clear, or we should be working more toward what is harm reduction. Is harm reduction just passing out paraphernalia? Does it include and really include treatment opportunities for folks, inpatient, outpatient services that would actually help one address that issue? And then coupled with mental health services to really ensure that we are meeting that individual. I really liked one of the recommendations, if I'm not mistaken, and I could hardly see because I'm on my phone, but if I'm not mistaken, one of your recommendations was to create spaces that are specific to people who are unhoused but in shelter or temporary housing, where that environment itself is a sober environment, which is critically important because when you are striving to, as a person with lived experience of substance use and sobriety, but when you're in a bad place, I'm talking about in your mind, a situation or circumstance, it is so easy to experience that desire to want to use when you're in an environment amongst who are currently using. And I'll stop right there, but I'm so excited that you're here and I'm looking forward to seeing you tomorrow at our Homeless Coalition. Thank you, Dr. Nicholas.
Yeah. Sure. Yeah. So we do, yeah, there is we do have beds in abstinence environments for that purpose. Yeah. And to your question about, yeah, the lived I agree with you that it would be important to speak with people who not only have the lived experience of homelessness, but also of substance use and addiction. I don't know. I mean, I'm going to be speaking with that group actually on December 20th. It's the Lived Experience Advisory Board at LASA. And I'll certainly be curious to ask because that would be a perspective that we would need. So I appreciate you
And I'd
raising.
be happy to support you in gathering a group of people who actually can identify with that area. Thank you.
Thank you so much. And yeah, Ria could be my contact on that to follow up on that. Thank you very much.
Thank you, Reba. Thank you, Dr. Nicholas. I am going to pass it to Bishop Byron, please.
Yes, good afternoon, Dr. Nicholas. I would like to, you mentioned that under your recommendations, was there anything that was missing? And as it relates to substance abuse and use and homelessness, what I've discovered is that those two kind of parallel, and not only parallel with homelessness and substance abuse, but the underlying issue of most substance use and abuse is mental health dysregulation. And so one of the things that I was wanting to inquire about under your recommendations was, I think you have some great recommendations, but one of the things I don't see is the psychoeducation around harm reduction as it relates to those who may be houseless or homeless, being able to understand the resources that are provided, because many times resources are available but because of the lack of insight and education around the resources, a lot of times those who might be homeless or houseless are less likely to want to go after it because of the stigma around their current situation and just reaching out for help. So I would like to see if it's possible to add into the recommendations a bullet point around psychoeducation and training with the population, so that they would really have a keen understanding of the resources that are available and how it can help them at their current need, whether that's substance use and abuse, whether that's mental dysregulation, or just seeking help for some physical conditions. But I think that the psychoeducation around all of the recommendations as it relates to substance use and abuse and harm reduction, I think is crucial as well.
Great.
Educating the population.
And if I can push you on that, so like you're talking about street-based outreach, or like where would that education happen?
I think, like you said, meet them where they are in the streets, but have like just like we do like town forums, have forums within the homeless population community where people that they trust can go in and educate them around the various topics that they're dealing with, such as substance abuse, mental dysregulation, mental health dysregulation, and the possibility of gaining access to the resources that are available. So, I mean, really just ground roots, but yet efficient and contextualized groups within the homeless population community, where you also building up rapport with those that are houseless, so that they would have a trust factor factored in to help get navigated into these resources. Because a lot of times we're throwing resources at them, throwing services at them, but not really educating them around how this can affect them to be better.
Excellent. Thank you. Very excellent suggestion. Appreciate that.
You're welcome. Thank you for your presentation.
That was like a benediction, Bishop Byron. Thank you so much. Dr. Nicholas, thank you so much for sharing your time with us today, and just, all of the effort that goes into creating this presentation. We also really appreciate your openness to incorporating all that we've shared today into the recommendations. And yeah, we'd love to know from you. You beat me to the punch, but next steps and how we may continue to support your efforts.
Yeah, so I'm in the process of pulling together everything that I'm gathering from our community meetings, and updating, revising the recommendations, sharing those back with our mortality prevention work group, our county work group, and then releasing the new data with the recommendations in January. Realistically, it'll probably be late January. Has to go through all approvals and things internally, but I'm all set. It's it's ready to be released by the end of January, and then we have opportunities then to share it more broadly. We'll start with the board deputies, but oftentimes we go to this SPA6 homeless council that we often present at, and we'll be at the vigil this year as well. So any opportunities that you can think of where we can get this information out more broadly would be greatly appreciated. But we'll definitely send you copies of the report when it is released. Yeah, next month. Just a little bit more than a month from now, and then we have our email addresses at the bottom of this slide too, so people can feel free to send inquiries or thoughts or questions there as well. So yeah, happy to come back. Yeah, happy to come back. At a future date to this as well.
I know we'd love to continue the conversation on how could they inform everything going on with Measure A, and we think about accountability, oversight, continued systemic racism within homelessness. So, how can we kind of use these data to inform next steps in that regard as well. So
Yeah.
I know a lot of people have asked about the slides. I am guessing that the data that you shared with us tonight and additional data will be presented in the public release report, correct?
Correct. Yeah, that's why I
Alright.
unfortunately can't share the slides yet because this is
We
pre-released. We
understand.
haven't released yet, but yeah, in about a month we'll be able to send you the full report. Yeah.
Yeah,
Awesome.
it would seem at that point we could perhaps give a more substantive and or considered um, response. And Madam Co-Chair, it may be the case that we would do that in written form based on the feedback from the collective of individuals who populate the homeless working group and their views as we can advance them. I think that would be a worthwhile
Absolutely.
endeavor on our part. So as soon as we get something um, in written form from you, Dr. Nicholas, it seems to me that our role might very well be to offer a fraternal critique of the data that you have shared.
Fantastic. Great.
Another benediction. Thank you, Supervisor.
Indeed, indeed, indeed.
All
Thank
right.
you. Thank you again, Dr. Nicholas. We really, really appreciate it. And we look forward to having you join us again.
All right.
So, um, we have a few announcements this evening as well. So thank you everyone for joining us for today's meeting. Our next meeting will be on Thursday, January 9th, 2025, next year. And then we are also excited to announce and share about our Empowerment Congress Summit happening on January 25th, 2025, with a Where Do We Go From Here? Chaos or Democracy. For additional information on the summit, I would like to direct you to our Empowerment Congress website. You will also receive information later after today's meeting and next week regarding the summit. So we look forward to seeing everyone next year, and we wish you a very happy holidays.
Thank you, Madam Chair.
And thank you. Good
Thank
night.
you.
Good night. Good night
Right.
to everyone.
Thank
Yeah.
you.
Thank you.
Thanks
Good
again,
night.
Dr. Nicholas. Bye.
Good night.
Good night.